This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
So thank you so much for the opportunity of being able to share a piece of work that we've done, and I'm hoping that some of these learnings might be useful to similar campuses that you may have. So I wanted to start off by giving you a bit of a geography study about Austin Health. So Austin Health is in the northeastern suburbs of Melbourne, and it has three main campuses. The main campus shown there is in Heidelberg. Then the next campus, which is just off that picture, which is the Heidelberg Repatriation Hospital, the one that I'm going to be speaking about today, and which is, had historically a sub-acute focus, but is becoming more acute as services are reopening on that campus. And then the third campus, which is the Royal Talbot campus, which is closer to the city in Kew, 7 kilometres away from the main campus, is a rehab centre. So I'm going to be speaking to you about this campus, which is the Heidelberg Repatriation Campus. Now, it's on quite a large block of land, and it's sprawled out. And this campus, as I said, has been subacute. And in the last 4 to 5 years, we've introduced acute services back into this campus, which include a surgery centre and a GEM ward, which admits directly from the emergency department. So we decided this would be a really good opportunity to review the way we were caring for the deteriorating subacute patient and to take those learnings and see what we could improve on and what could improve the patient's journey. So we started off by doing a day in the life of the organisation, so a bit of a dialogue. What were we dealing with on this campus? So on this campus, this was just a snapshot in a day. On this day that I did the snapshot, there were 1,006 patients visiting outpatient departments on this campus, and they all brought a mate. So there were over 2,000 people visiting our campus every day. On this day, there were 208 patients spending the night, and also on this day, there were 61 surgeries that occurred on this campus. These are the units that are represented. So most of the organisation has representation at the repatriation campus, except for oncology, which used to be there and has moved across to the ONJ building, Olivia Newton-John building. So in the retrospective study we did on these MER calls, 143 patients were reviewed, and of them, just over 50% of them were transferred across to the ICU at the Austin. That is normal practice on our campus for a deteriorating patient. So a patient who's in deteriorating rapid response criteria is reviewed. If the responding team believes that they cannot safely care for this patient on the repad campus, this patient is then put in an ambulance and sent across to ICU, where they are reviewed and a care pathway determined. If you're an outpatient and you deteriorate on the campus, you go in an ambulance to the emergency department. So we were specifically looking at what were our subacute patients, how were we treating them, and how effective was this process in caring for them. So 50% went to ICU. Of those 50%, 28% died there. So we were sending our end-of-life care patients to die in the ICU, and a further 17% died later or palliated later in the same hospital stay of those that we had sent to the ICU. So we have to stop and think, is this the best care plan for our patient? Is it the best outcome? So it gave us an opportunity to review all MER calls, and we started to put some systems and processes in place that brought about some, so this is where we started, and this is where we are today. We've had some spikes, which I can speak to you about just now, but at the end of the day, we have a much larger throughput in our campus, much larger throughput in surgery, much larger throughput in our bed occupancy. We've introduced a program called Expected Discharge Date. So we make sure that our patients are discharged as close to the date or earlier as predicted, so that we try and minimize unexpected stays. And this project has increased throughput on the campus significantly. So if you have a look, we are lower than we were when we started out in this process, and yet we have much larger throughput. So having just breaking down the MER calls, so you can see this is the subacute group. So these wards have come down in 2014 and predicted to be even lower in 2015. Ward 10 is the GEM unit, which is admitting directly from the emergency department, and they've had much higher throughput, but are stabilizing in their number of emergency response calls. The surgery centre has gone up since we started, and they're doing nearly 2,000 patients more a year, so that increase in rapid responses is really nominal compared to the throughput. And then outpatient department, we've done a piece of work in outpatient department which have seen a significant reduction in the number of emergency calls, and it's sustainable. So I wanted to speak to you about what did we do to bring about these changes. So it needed some significant leadership, and I partnered with Darryl Jones and his team, which was fantastic, and also Michael Murray, Professor Michael Murray, who is a geriatrician working in our sub-acute area, and together we came up with some strategies that we needed to improve the outcome for the patient. So what did we do? We improved mortality and morbidity meetings, M&M meetings, so we discussed cases and came up with ways of improving care. Also followed up on emergency calls and reviewed how did this patient get into emergency call criteria and what could we have done earlier. We improved the clinical care of a deteriorating patient through education and increasing the seniority of medical representation on the REPAT campus, which has helped enormously. A clinical focus preempting deterioration and death so that we could have systems and processes in place. So we did not transfer our end-of-life care patient to die in ICU, but rather to stay on the ward where this patient was well known and cared for, and the family had a relationship with the staff. And a major focus on communication re goals of care so that we were all clear about when this patient was admitted what we were hoping to achieve and getting as close to possible as achieving this. And increased respecting patient choices presence on our campus. So we've employed and increased the hours of a representative on our campus so that they can speak to our patients and come up with their goals of care that they'd like in their hospital stay. And the registrar role to target the declining patient every single day. So the declining patient was on a list and got reviewed every single day and fed up to Michael Murray, and they came up with a care plan for these patients. So intense medical leadership in every single deteriorating patient or prospective deteriorating patient. What did we do from a nursing perspective? The first thing we did in gap analysis. So we went to the nurses who responded to these medical emergency calls. So we do not have a dedicated medical emergency team on our campus. Senior nurses and the medical registrar respond to deteriorating patients with a site manager, and together the decision is made, is this patient going to stay on this campus or are we going to transfer them in an ambulance back to Austin, and what is it that we're wanting to achieve? So we met the senior nurses who respond to these medical emergency calls, and we asked them what they needed to be able to be more efficient. In the gap analysis we did, they felt that they knew knowledge, but they really, really wanted to be buffed up, and we used the vehicle of Compass, which is a training program, and 80% of all nurses on our campus have gone through the training program, and as I'm speaking, by the end of this month, we plan to have 100% of our nurses who have gone through this training program. We've also had an additional emergency team, so we used to only have one. The second team comes out of the surgery centre, and 2 teams respond. Having the acute skills of the surgery centre nurses responding with the medical knowledge of the sub-acute nurses has been a fantastic combination. Also, the team has been buffed up. If we need to escalate to a code blue, the recovery and the theatre nurses and anaesthetists respond, which has been very useful. We're also in discussion with medical units about appropriate transfers before we really are in in an emergency response, we try and identify these patients long before they escalate so that we can have discussions. We can respond and not always react in making emergency decisions, which has been very useful. We have advanced care plans for rehab patients. If we have a look at our rehab subacute patients, many of these patients are having multiple admissions, and so we make sure that they have advanced care plans in place so that we take into consideration their wishes too. The surgery centre, if they have a patient who's requiring a rapid response, they have a seamless way of getting their patients back into the recovery in our hospital at the Austin. And this seamless way means that they identify these patients long before they deteriorate. They make some phone calls, and this patient gets to the recovery in a really timely manner, which has been a very good outcome. We have increased the education on our campus. We have multiple onion layer approach to education on our campus, bedside education, formal education, but a lot of it takes place at the bedside. We take learnings, so if we've had a medical emergency response that has not gone particularly well, we call meetings, we have learnings, what can we learn from it so that we can become more efficient, and this has built confidence, which has been a really good thing. We have a new layer in our medical emergency response. We have a layer called an urgent clinical response. This urgent clinical response has been probably one of the single most successful introductions into the managing of a deteriorating patient, because we identify them long before they deteriorate. We start to make calls with consultants at the main campus, sometimes ICU, and we come up with care plans, and we have reduced the number of patients that have moved over to ICU significantly, and it's more than 60%. We have decreased it, and I think that the urgent clinical review and identifying patients long before they deteriorated has been probably the single biggest success factor. And then this whole plan of managing deteriorating patient and getting it embedded has enjoyed executive support, and I think that that has also been critical. When you make these changes and you want them to be sustainable, you have to have your executive on board, and that has been a very useful exercise for us. So I wanted to take some of those spikes in our data and just explain to you some pieces of work that we've done around and what we've done to reduce MER calls, medical emergency response calls. So on our campus we have this beautiful new rehab centre, and patients come in taxis as outpatients to this rehab centre, and they form part of a physio outpatient group. And what was happening was we were having MER calls occurring down in this rehab centre, not a lot, 16 a year, but each one took 2 to 3 hours to sort out, and the doctors and the nurses were away from their own patient groups caring for these patients who were deteriorating in the rehab centre. And so we wanted to get to the root cause of it, what was going on and what could we do. So I spent a morning in the rehab centre, and it didn't take me long to work out what the problem was. So patients were coming out of the taxi or from their family vehicle, going to get onto a piece of equipment, waiting for the physio to start the session, and then the session would start. Nobody asked them, "Are you well today? Have you had your breakfast? Did you have your medication?" So because it's a hospital, people were coming and they were unwell and they were taking part. And this tiny, tiny little piece of work that took me a morning has reduced the number of medical emergencies in that area significantly. And if you take the hours and add them up, and you take the outcome for the patient, it's a tiny bite-sized little success story. We did the same in the surgery centre. We reviewed the number of MER calls that were occurring in neurology patients in the surgery centre. We broke it down. We presented it to the urology team, and we asked them if they had an idea what the root cause of these medical emergency calls were about. And without blinking, they said, yes, we know the problem is bladder washouts. We don't think that the nursing team fully understand the fluid balance management of a bladder washout. We did an educational session one day. All the surgery centre nurses came in for a special education session. To date, that was 2.5 years ago, to my knowledge, in the reviews of the medical emergencies that I do, which I do every month, there has not been one medical emergency that has occurred around a bladder washout. So we're very quick to respond, but sometimes I think we need to work out why did it occur in the first place. Here is Ward 10. This is the Gen Med ward, newly refurbed, up and running in the last 4 years, receiving patients directly from ED. And this is their throughput, the increase of patients, and as you saw, the medical emergencies that take place in this unit have stabilized as if it was 3 or 4 years ago. They have not increased because of these systems and processes we've put in place. And the same with the surgery center. So beautifully new revamped theatres, 8 of them, doing up to 60 surgeries a day. Look at the increase that they've had through their throughput. From 7.2 thousand to 9,000, and their medical emergencies have increased incrementally, but not in the same ratio as the throughput. So, in conclusion, the piece of work that we've done at the REPAT has been a joint effort, a team effort of medical nursing putting their thinking caps on, having a look at the data and coming up with plans that manage the deteriorating patient before the deterioration is significant, and obviously this is non-catastrophic events, using urgent clinical review and coming up with plans that we can put in place for our patients to care for them safely when they're deteriorating and getting them the right kind of care in a timely manner.